joining. We are just waiting a little bit while it's 11 o'clock. Everybody is welcome, and please try to make your names or your tags, put your name so that we know who is talking or who is asking the question. And we will start with the seminar in 2 or 3 minutes. Welcome, everyone. So good morning, everyone. We are still waiting for 11 o'clock to start with the seminar officially. In the meantime, I just give you all a good morning and welcome to this seminar.
Good morning.
Good morning, Maren. Nice to see you.
Maren.
Hi, Annelies.
Good to see you.
Oh, yes. The same for me.
And good morning to Chloe, who is saying Chloe Plumetas. I don't know if I pronounce it well. It's saying hello to everyone. So good morning, Chloe. Thanks for joining as well.
Good morning, sister.
Oh, Peter.
That's my brother.
Hi, Maren, grüß dich.
Peter, this is not a private chat, okay?
Goedemorgen, Peter, and welcome.
5 people or more?
We have 55 now, Peter.
55, okay.
Yes.
I put on mute, okay? Sorry about that.
Yes, I will invite everyone just to put their microphones on mute, please, so that we avoid background noise. As we start approaching 11, it's really a pleasure for us to welcome Professor Annelies Wilder-Smith. Just a reminder for everyone to keep their microphones off. It's nice to hear the bells reminding us that it's 11 o'clock, but just please keep in mind the microphones. So as I was saying, it's really a pleasure and an honor for us to have Professor Annelies Wilder-Smith. Professor Annelies Wilder-Smith has been all over the world, succeeding in all kinds of different roles. She is now a professor of emerging infectious diseases in the London School of Hygiene and Tropical Medicine. She has worked in many different infectious diseases, including Zika, I think SARS, yellow fever. She was part of that SARS issue that we had a few years ago with chikungunya, dengue, and now she's very much involved in COVID-19. She's part of the WHO vaccine research initiative. So yesterday we got the news from Pfizer, a press release. Their value went up. We wonder whether this is just a marketing strategy or a scientific effort, or whether there is a solution and how feasible and how near the solution is. So we couldn't have a better time for this talk than today, Annelies. So thanks a lot, and thank you everyone for joining. Thank you, Hornor Rashid, who is joining us from Sydney. Thanks a lot for being there. Thanks everyone, wherever you are. Please keep safe, and let's proceed with the seminar. Professor Wilder-Smith, please.
Well, thank you. Thanks to Professor Oscar Franco for inviting me today. And thank you for the ISBM team and staff for being here, as well as many friends and colleagues, and even my own brother. And I think my daughter will join too, from all around the world who are now listening to this talk. It doesn't move forward. All right. So it is a serious situation. As of 5 November 2020, the cumulative number of COVID-19 cases notified to WHO was close to 48 million, with sadly more than 1.2 million deaths. Within 24 hours, more than 500,000 new cases were reported, with 9,000 deaths. The epidemic curve is strikingly different by region and by countries, underpinning again how this pathogen moves in clusters is driven by population densities, driven by urbanization, but the epidemic also is highly reflective of the extent of the pandemic response that different governments have implemented. So each country or each region is at a different stage of the epidemic. Europe, as you all know, is currently experiencing its second wave. Africa and parts of South Asia are on the decline, while the Americas continue unabated. We also have to acknowledge, and it's very important, that some countries have successfully contained the outbreak, and these countries include China, New Zealand, Australia, Singapore, where I lived for almost 20 years, Taiwan, Vietnam, South Korea, and many others. The 5 countries with the highest numbers are the United States, Brazil, India, Russia, Mexico, and France. And these 5 countries combined present more than 50% of all cases worldwide. So while lockdowns are successful in containing COVID, we all know, we don't need to discuss, we cannot continue indefinitely with lockdowns. And we also need to acknowledge that when we do reopen, most of the populations are still at high risk, are still susceptible. We also know that if you open one country and we haven't solved the problem in another country, that we are so interconnected and it undermines every country's efforts in this pandemic. So it's only together that we are closer. Therefore, there is a strong case to act. So ACT stands for the access to COVID-19 tools, ACT, and the A stands for accelerator. So the ACT accelerator is a relatively new, groundbreaking global collaboration to accelerate the development of production of vaccines, therapeutics, and diagnostics, and also to ensure, and it's very important and the main topic of today, to ensure equitable access. COVID was declared a public health emergency on 31 January 2020. By April, this is really an unprecedented scale of speed, ACTA was already launched with pledging events that took place in May, and by now, more than 180 countries have joined ACTA. This makes up to 6.8 billion of the world's population. This is really an impressive effort. And actually most countries joined, except, and that's notable, except for the United States and Russia. And for information, China did join. So COVAX is the vaccines pillar. So there are 3 pillars: vaccines, diagnostics, and therapeutics. And today we'll focus on the vaccines, obviously. So COVAX is the vaccines pillar of the ACT accelerator. COVAX goals are to end the acute phase of the pandemic, to deliver 2 billion doses by the end of 2021, to guarantee fair and equitable access to vaccines for all countries, to support the largest actively managed portfolio of vaccine candidates globally, and I will show you the portfolio of the platforms and individual vaccine candidates shortly, and to offer a compelling return on investment by delivering COVID-19 vaccines as quickly as possible. So the COVAX facility at its core is a risk-sharing mechanism. To reduce the risk for countries concerned about failing to secure access to a viable vaccine, and at the same time reducing also the risk to the industry, to the manufacturers that are concerned about their upfront investment without an assured demand. So all countries in the world have been invited to participate. Participant countries will receive access to all vaccines. And the beauty of this kind of COVAX is you do a priori negotiations with the manufacturers for negotiated prices so that they become affordable for all. So you have an a priori investment into the COVAX So you have access to all the platforms, thereby risk sharing in case one vaccine fails and another wins. There's also an advanced market commitment, and those countries from lower middle income countries will be supported through overseas development aid funding. So again, the aim is 2 billion doses by the end of 2021. So there are 3 components in forming the formulation of vaccination strategies. And today, really, my talk is very much from my perspective from SAGE. And so basically all my thinking is through the process that I've gone through SAGE. But just to give you the overview of the 3 strategies. So we have the allocation framework, which is part of COVAX. It sets the frame for the overarching public health goals and priorities, is still candidate independent. That means vaccine candidate independent. Then, of course, when vaccines have completed their phase 3 trials, they go through a very rigorous regulatory process and safety monitoring, and they guide around those issues. And with that knowledge, SAGE is a group of experts in vaccines, then provide guidance and policy advice on specific vaccine candidates. So we formulate vaccine strategies. We formulate vaccine strategies as SAGE for the globe, for the world. So it's not country specific, and therefore countries still are responsible for the final decision on in-country policy allocation and vaccine strategy, because the situation does differ between countries and there may be different priorities. So this is what the allocation framework and the allocation mechanism have put forward based on country input. So this is based on an extensive and long consultative process. So the overall goal is to protect public health and minimize societal and economic impact by reducing COVID-19 mortality. And so the agreement that already exists within COVAX is that every country, so participants here are countries, participants receive doses proportionally to their total population. And obviously, as the vaccine will not come in all at once, it will come in a staggered way. We will also have a staggered rollout. And so up to the first 20%, that's important to understand, it is an equal distribution between countries. Above 20% of the vaccine allocation will then depend on the epidemiological situation of a country and the vulnerability of the country. So initially it's thought that we will only have 3%, and then the idea is to give it to the health and social care workers, and then to the high-risk adults, and then the further prioritization then depends on many, many other factors that we then need to think of once we are at that stage. So let's move to the vaccine landscape. So clinical development normally, has to go sequentially from discovery, phase 1, phase 2, phase 3, licensure, policy making, and then roll out. We cannot afford these years of waiting. So we have to compress the timelines. That does not mean, and it is so important that we communicate this to the public, it does not mean we are cutting corners. That is not what it means. It means we are compressing processes. So instead of going sequentially, we're going in parallel with many of the processes. That includes, for example, us now, I'm in the policy guidance. Even before we know about the vaccine, we have already been meeting 22 times over the past 2 or 3 months to think through all the issues, so that once the vaccine is licensed, we can immediately formulate the policy. So of course, also this compression comes at some risk, because we also have started the manufacturing process in parallel with the phase 1 or phase 2 trials. And that is the risk that we're taking. So we are investing in manufacturing capabilities now, although we do not know whether they're really efficacious and safe in the end. And we're doing it now with the risk that we may need to discard a vaccine, but we're doing it for the benefit that we do not have to wait years between finding out that the vaccine actually works and then manufacturing and having it at scale. So these are the types of vaccines that we have. All currently available platforms are being used, well-established ones as well as novel platforms. And as you can see, these include the well-established virus vaccines, be it the live attenuated or inactivated vaccines, viral vector vaccines, be it replicating or non-replicating, the nucleic acid vaccines, be it DNA or RNA, and protein-based vaccines, be it protein subunit or viral-like particles. Let me briefly, most of you know all these vaccine platforms, but the nucleic acid vaccines are relatively new. So let me delve briefly into this. So RNA vaccines work by introducing an mRNA sequence, which is then coded for the spike of the COVID-19 virus, of SARS-CoV-2 virus, and then enter in the body. And once produced within the body, it's recognized as an antigen. The beauty or the advantage of nucleic acid vaccines, although relatively new, they are much faster to develop. And that's why you see they were the very first one to go into phase 3 trial. And Pfizer was also the very first one now to make an interim analysis. They're faster. They're actually also cheaper than traditional vaccines. And they possibly, but there we need more data, but theoretically, they may be even safer as they have some characteristics of a live attenuated vaccine, but it still does not produce infectious elements. So this is the overview of the vaccine platforms and their attributes, so their relative advantages. So we have more than 300 vaccines now in development, most of them still preclinical. 11 are now in clinical trial. The most, as you already see here, because of the advantages of the RNA vaccines, you see there's a high number, quite a big number in that development. And so some will have, most vaccines we already now know will not be able just to have a single dose. What we really want is a single dose, of course, but we have to live with the reality. Some of them already have a license platform. That means a track record of a platform. So for example, the inactivated vaccines, live vaccines have a very good platform. And some are very fast to develop initially. But then you also want to know what is the, sorry, I need to change here something. What is the manufacturing scalability? What's the manufacturing scalability to really produce massive amounts? And of course, there you need well-established vaccine developers. So each vaccine will have its advantage and disadvantage, and probably also in terms of vaccine performance. And it's important that we have all the platforms in development. And to also tell you, the front runner does not necessarily mean the final winner. In fact, we need many winners because we know that scalability of any single product will never be sufficient for the global market. And the global market, what is the population size, is 7.7 billion. So this is the landscape. You know, the London School, they have these regular vaccine pipeline trackers. WHO also does it. There are currently 11 vaccines in phase 3 trials. And again, the platforms are actually involved, most of the platforms. So CureVac, BioNTech, Pfizer, that we heard yesterday, Moderna, they are RNA vaccines. AstraZeneca is a chimpanzee adenovector vaccine developed by Oxford University in the UK, and is also a front runner, will also soon complete phase 3 trials. Johnson & Johnson, or the Janssen, is an adenovector vaccine. Novavax is a recombinant protein nanoparticle technology using a vaccine. Sinopharm and Sinovac are produced in China. They are inactivated vaccines. CanSino, also from China, is a non-replicating adenovirus, and Gamaleya is also an adenovirus type 5 vectored vaccine, and that's produced in Russia. So a lot of vaccines, and we do at this stage, we do, and that's very important for all of us to know, we do not have phase 3 clinical trials. Only when we have phase 3 clinical trials based on 10,000s of subjects can we make good recommendations. So, but it does look promising. So the early clinical data from COVAX candidates do look promising based on immunogenicity, that they all have relatively good antibody titers. They've all shown to have also cellular immune response induced. The safety profile to date looks like they are generally well tolerated, although some trials have been paused for a short time to evaluate safety events, but they all restarted following regulatory approval. And basically, all the vaccines currently in phase 3 trials have enough data from phase 1 and 2 to substantiate the need for the phase 3 to move ahead into an expanded safety and efficacy trials of phase 3. And as you know, phase 3 trials include 30, 40, Johnson even has 60,000 subjects. But because we do not have at this stage phase 3 results available, we live with uncertainties. Yet, in a time of uncertainty, we as SAGE and the whole world already need to prepare the delivery. And so what are the uncertainties? First of all, very important fact, what we really need to know, does the vaccine prevent severe disease? Or does it just prevent infection and mild disease? Or does it prevent both? Does it also help reduce transmission? Will it have an indirect impact? We don't know. We also don't know the extent of vaccine efficacy. We don't know the safety. We can only infer from the vaccine platform track record. Very important question for COVID is, will there be a differential efficacy dependent on age and comorbidities? Basically, most vaccines have a lower efficacy in higher age groups. So this is a very important question. And I can tell you now, by the end of phase 3, even if we have phase 3 trial results, we will not have enough data to answer this question in particular. Then we also don't know which vaccine will come out when. Will they all come out in one go? Will they come out staggered? Which one will be first? We don't know. We also don't know the amount that will be available in the first tranche, but we expect it. That's based on our COVAX estimates. It is initially to be 3 to 10%. We also do not know the duration of immunity in natural disease, and which may then also, in fact, vaccine-induced immunity and its duration. So in the absence of phase 3 trial results, what we then decided to do, and I usually ask the students, what would you do if you were in SAGE? If you now have to make recommendations for the world, how would you do it? What would you do it? What expertise do you need to get? What consensus? And this is what we came up with. So we developed a 3-step process where we decided that we would first go for the values framework. So where we decided that we would need the ethical background, the values that would underpin decisions on allocations and prioritizations. And indeed, we've developed this, and I will share with you in a moment. And this was endorsed by SAGE and is now published. And then we started working on pulling the evidence together using the values framework to write a guidance paper on how to prioritize target populations under supply constrained situations, under limited vaccine supply. And in the future, and it could be very soon, in the very near future, we will then, when we have a vaccine that has completed phase 3 and is licensed, has gone through a regulatory review, then we will make policy recommendations specific for the vaccines. So let me now start and bring you through our thinking around the values framework. So this picture is months of work. So we developed 6 core principles: human well-being, not only to protect and promote human well-being, including health, social and economic security, human rights, and civil liberties, but also child development. Although this disease affects mainly the older people, children have particularly suffered, and we have particular emphasis on child development, which you will see reflected in our prioritization later on. Equal respect, recognize and treat all humans as having equal moral status and their interests as deserving of equal moral consideration. Global and national equity ensure that there's equity in vaccine allocation between countries, and this is COVAX's role, COVAX is doing it, but also within countries. Here, COVAX cannot play a role, this must be done within countries. Reciprocity. Reciprocity means you honor obligations of reciprocity to those individuals or groups within countries who bear significant additional risks and burdens of COVID-19 response for the benefit of the society. So this is clearly the health workers, but also essential workers, food supply, transport, police, etc. And lastly, legitimacy. This is make global decisions about vaccine allocation and national decisions about vaccine prioritization through transparent processes that are based on our shared values and based on best available scientific evidence with appropriate representation and input by affected parties. So these were our 6 core principles that we put together as the foundation for all subsequent discussions. And so you can then see these principles are then allocated to public health objectives, to reduce deaths, to reduce societal and economic disruption, and to make sure that essential services continue. To make sure that it also accounts for vulnerabilities. That means for certain socioeconomic groups that have a higher risk or experience a greater burden from the disease or from the pandemic response of lockdown, for example. And then also the need for reciprocity. So after we now had the values that now fit into the public health objectives, we had to go to the science to look, how do we now prioritize the most, those that would most benefit from vaccination. So in the many uncertainties that I've shared with you, there's one thing that's absolutely certain, and that is, that the vaccine supply initially is limited. And so we need the science now to direct us how best to deploy a vaccine under limited vaccine supplies. So what's apparent from this group, these 2 figures, is the following. While the bulk of disease, while the bulk of infections, the bulk of morbidity is in the age groups of 20 to 60, the bulk of deaths is clearly in those aged 60 and above. Men are more likely to die than women, and the magnitude of this difference widens in the older age groups, except in the very, very old, where there are more deaths in women than in men, probably due to the mere fact that more women live longer. The infection fatality rate, which is presented in the table on the right, as you all know, we always rely on acute case fatality rate, but it's the infection fatality rate that we need to understand better. And it's defined as the proportion of infected individuals that die. Now, this proportion then also needs to include asymptomatically infected or mildly infected, or people who are infected and never see testing are therefore not reported. So this number, this infection fatality rate, needs to be taken from seroprevalence studies or estimated by modeling the case ascertainment rate. And as you can see very clearly, the very strong association between age and mortality, and also very important, is that the age stratified IFR is more useful than a general mean IFR. No, I just cannot cope with people telling me this is the IFR. It has to be age stratified to be meaningful. And then it also makes more sense between countries. And I want to show you the difference between countries in this paper published by Science. So most data that we have access to are from high-income countries, but WHO makes recommendations for all countries, and maybe even more especially for LMICs. Here, paper compares mortality rates from the US versus India. In green is India, in purple is the United States. Life expectancy at birth in India is 69, and in the US it is 79. Here you see figure A, which is the population age structure. And you can see that the population age structure is far younger in India compared to the US. Figure B shows the case age distribution of COVID cases. The incidence, interestingly, you see in C, is pretty similar between the US and India. But what is different is that the age distribution of deaths is in a far younger age group for India compared to the US. So whilst in the US, you will see that more than 75% of deaths are in those older than the age of 75, you will see here in green, in D, that the vast majority of deaths in India and probably many other LMICs, including Africa, is in the age group of 50 to 64. So we need to take this into account as WHO when we make global recommendations. So ISARC is an international network of hospitalized patients, and probably has one of the best databases on COVID, on hospitalized COVID. In this observational study published by ISARC, and I'm part of the steering committee of ISARC, included more than 20,000 hospitalized cases in 200 hospitals in the UK. In this database, the case fatality rate was 26%. 26% of hospitalized cases died. And this is actually quite consistent with what we see. So people always talk about IFRs. You actually have to talk about also the hospitalization, how many of hospitalized patients actually die. So ISARC did a multivariable Cox proportional hazards model where hazard is death. Also here, you see that high age alone is the main risk factor. And I'm not so sure if you actually see my thingy. Do you see it? So the highest hazard ratios are dependent on age, much more dependent. So age is a bigger driver, has a much higher hazard ratio than any of the chronic comorbidities. We already know the chronic comorbidities. We also know it includes obesity and the other well-defined cardiac, pulmonary hypertension, malignancy, chronic kidney disease, liver disease, etc. Here again, you see that being female is protective. So at least once we have an advantage in our life. So now comorbidities and age structures. I've showed you that age structures differ by country, but the proportion will also differ between countries and between regions. But for vaccine allocation purposes, where you want to target high-risk groups, it's important to get a feel for the size of the population. So this is a Lancet article, that is extremely important for all our decisions. It publishes global, regional, and national estimates of comorbidities by age. It considers 11 underlying so-called comorbidities for 188 countries. So basically almost every country can now look up and see what is the proportion of my high-risk groups. Again, also here you will see that the proportion of older people above 60 is clearly higher than in high-income countries than for LMICs, and the same for comorbidities. The global proportion of people with comorbidities is 22%, regardless of age. This is obviously higher for Europe and maybe lower for Africa, but overall 22%. And remember that we think initially in our vaccine allocation, we only had 3 to 10% and maybe later 20%. So even within this population, we cannot cover everyone. Let's move now to healthcare workers. PAHO, no, actually, here it's Amnesty International. They announced that 7,000 healthcare workers have died around the world because of COVID-19. Here you see the numbers from Mexico, from the US, UK. Over 7,000 people have died. For over 7,000 people to die while trying to save others is a crisis of staggering scale. And that is why we feel that healthcare workers are so important. And I think we have global consensus on this. So now let's move to the 3 priority populations. And the 3 priority populations are clearly defined here as those that have an individual higher risk of death or severe disease outcomes because of underlying medical conditions or just based on age. Then those who are at risk of exposure, of continued exposure because they cannot do social distancing because they are essential workers, and they include healthcare workers. And the third group are those who contribute most to transmission. So the latter are people with high contact rates, high contact frequency, and are now good data for modeling on contact densities, etc. These include children, university students, and anyone who has a high contact rates. Obviously, the characteristics of these 3 groups overlap. And on the right, you will then see the examples of potential target groups that you could then order. So this is the order that we had initially. Those elderly, healthcare workers, younger age with comorbidities, essential workers, adults living in densely populated areas. That is the transmitting people. And then the rest of the population. So now let's look again at the size of these target populations so that you get a feel for the enormous task ahead. So the global population is 7.7 billion, of which about 2 billion are children and the so-called rest of the adult population. So they're out of the initial strategy. But even if you look at the global population, those aged above 65 is still 700 million people. Those below 65 and have underlying condition is more than 1 billion persons. Workers in health and social care represent 136 million. Other essential workers, 1.2 billion. Adults living in densely populated areas, 751 million. So when you have uncertainties and you have different scenarios, what do you do? Where do you go to? So as SAGE, where did we go to? Like everyone else, we went to the modelers. And we posted an official WHO call for mathematical modeling groups to work with us to address a pre-agreed set of questions. So as a working group, we spent weeks defining the questions. And I'm mentioning this call specifically to this audience because I know that within ISPM, there are excellent modelers. And if you have not seen this call, please write to me. Although the deadline is closed, we're still doing a rolling review, and we have big weekly calls with mathematical modelers around the world. Obviously, we're also very much looking for modelers from LMICs. So here are some of the questions that we put. So what priority groups? What would be the impact of vaccine on different outcomes, infections, deaths, and years of life lost, dependent on different scenarios for different target groups that I already discussed with you before. Those at higher risk, those who cannot socially distance, and those who are the big transmitters. And then how do you model then with all these data the optimal strategies to go for? In the US, for example, there's a lot of modeling going on, which economic groups you have to do to ensure that your GDP remains high. At WHO level, we are thinking more equitably around optimal strategies to ensure that we reduce deaths. And then equity. So how would health impacts be distributed across country income and also within countries? So, for example, to use modeling to justify to a country not to hoard the vaccines for its own country, but to understand that they will benefit themselves if they share the vaccines with other countries. Because as you know, if there's still a case somewhere else, you as a country are still impacted. So we as a SAGE working group provide core shared scenarios and assumptions where, for example, the counterfactual scenario is you do not use non-pharmaceutical interventions, or you do use, we have different vaccine characteristics. Is it a vaccine that is good against infection and disease, or just against disease? Is it the same for all ages, or is it better for younger ages? What is the coverage? What's the supply scenario, and what is the time horizon? So we're providing this. So when you work with us, that is the scenarios we are thinking through and walking through. And then there are, of course, there is no other disease, as you all know, that has such an impact on our economy and social life than COVID. So we also put the other very, very important questions on the role. How can we preserve and essential services? So how do you vaccinate to keep essential services going? What can we do to return to normal? What has the greatest impact with limited vaccine supply? What is the most cost effective, and where's the full value of vaccine? Now, we spent hours discussing these questions, but as a group, every time we come to the same conclusion. In the end, if we just focus on reducing deaths, so the health impact, we can reopen and the economy can rebound. So the most important pressing question for the moment are the first three questions that I shared with you just before. So we invited several modelers, and I will not show you all the modeling. We have just listened to many modeling groups, but I want to share that basically all modeling groups that have presented to us come up with the same key finding. And that we all already know, and the curve to the left is the same as the table before. It is just log transformed at scale. But clearly, those aged above 60 or 65 are at higher risk. In fact, most modelers say that the threshold is probably 60. But most of us still use 65 because it's our retirement threshold. But that is arbitrary. And without showing too much data, but here you can see the purple curve on the left, which is if you just go for adults above 60, and you can see with limited vaccine supply, this will result in the biggest reduction on deaths. Even if you assume, which we all do, that the vaccine in older is less efficacious in younger people than in younger people, it still is better than when you go for younger people. And then the impact if you vaccinate children or younger adults is close to zero. Now we need to remember that all this is because we are currently focusing on limited vaccine supply. Once we have a bigger vaccine supply, and we can ensure better vaccine coverage rates, then our thinking may shift towards prioritizing those that are the transmitters. So if you then reduce transmission, you have an indirect impact in the case the vaccine has an effect on transmission, and thereby indirectly you protect older people without even having to vaccinate them. But remember, all our thinking is towards limited vaccine supply where you cannot reach high vaccine coverage rates. These are slides from the ACIP, the American Committee of Immunization Practices, that had its fantastic meeting last week, and which was open. I listened, and this is a slide directly from them. And here, this is a slide from Biggerstaff, I think his name is, who looked at averting infections versus averting deaths. if you look only at infections, then he says, they say, actually going for high-risk adults and essential workers is more effective than going for the older people. However, if you go to avert deaths, then clearly it's also in line with what we have heard, you still go for the older people, regardless of comorbidities. Only then you go for high-risk adults based on comorbidities or high exposure and the essential workers. So really to avert deaths, which is our first objective that we came up with or that we all agreed upon, is you go for the older age group. This slide also, I think, nicely shows that indeed your impact, your vaccine impact, will also depend on when in the epidemic you actually give the vaccine. So if the epidemic curve is still rising, obviously your impact is much higher than when it's already declined. So we then, with all this information, based on the values framework, we then set out and to write our prioritization roadmap. And this were all the dimensions we had to take into account. The epidemiological scenario. Most countries have widespread community transmission, but some have very limited transmission, and a few countries have no transmission. And we need to give advice to all these countries. So how, and the strategy will be different between the country that has no cases like New Zealand that wants to protect the borders versus, or like China, than others. Then we have identified a public health strategy. And as I said, initially, it is just trying to avert deaths. And then the vaccine scenarios. So we define between very limited, limited, and moderate vaccine scenarios. And this is the roadmap that we then tried to write, and we rewrote it with the intention to support countries, because countries have to start now preparing for vaccine rollout. And so to give them some guidance, we wrote this roadmap. We had to use certain key assumptions. One was that a vaccine would meet all minimum criteria of the target product profile. And the minimum criteria is a minimum of 50% efficacy with a lower bound of 30%. We also said it would need to have a certain amount of efficacy in older age groups, even if it's not so high as compared to younger age groups. We also said non-pharmaceutical interventions, so all our social distancing, etc., still need to be continued in the initial supply. And this is very important to communicate to the public early on. We also said that we would take the effect of a vaccine on transmission less into account, because we, first of all, do not know whether the vaccine does it. And secondly, if you cannot have high vaccine coverage rates, it's not such an important decision driver. We also did not take into account seroprevalence. And as you know, seroprevalence is rising in the population and so forth. So we have the very limited supply, and a moderate supply. We have the three scenarios of community transmission, only sporadic transmission, and currently no cases. And this is our roadmap. All this whole talk for this table. There are actually three tables, but I will only show you the community transmission table, because this applies to most countries globally and especially applies to all of Europe, and most of us are here from Europe. Let me walk you through this table. So in this very limited supply, that is stage 1, where you have very limited, could be 1%, 3%, or up to 10%, the very first launch would be to target healthcare workers. Also not health workers, because some actually are not patient fronting, but really to target high to very high risk. And there's a definition, and there's a document that actually defines health workers at high to very high risk of acquiring and transmitting the infection. And then it would be, and why healthcare workers? It was the principle of reciprocity, our value. They're giving us their service. We have to return protection, but it's also because health workers are not only at risk of increased risk of exposure, there's increasing evidence that the higher force of infection actually also puts them at higher risk of severe disease outcomes, including death. And third, of course, we need to keep the health system working, functioning, and we cannot afford healthcare workers who have to stay at home because they're ill and off work. And then at the stage 1B, where we're still very limited, we would start vaccinating older persons. So you now will see that we just write older persons defined by age-based risk specific to the country and region. Because we are so global, we cannot give an age cutoff, and countries have to determine. So the age cutoff is higher in high-income countries, but lower in low-income countries. I hope I made this clear. So whilst a lot of national immunization technical advisory boards give exact thresholds, we have to leave this to individual countries. Then when we have the first stage over and we do have a little bit more vaccine, we go into stage 2. Now here, the order is not ranked. Countries can decide in which order they would go. So the order I'm reflecting here does not mean this is the order a country has to go. But the idea is you would then cover all the older adults you have not mentioned to cover before. Remember, just an age cutoff above 65 is 20% of the population. Then you would give it to individuals with comorbidities who are determined to be at significantly higher risk of severe disease or death. And we've talked about comorbidities. And then social demographic groups also at significantly higher risk of severe disease or death. Now here, we refer obviously to populations who cannot socially distance, either because they live in countries or societies or groups in multi-generational families that they cannot, or they have to go to work because they're essential workers and they cannot protect themselves, or they are in areas of high densities like slums, refugee settings, detention camps, prisons. And lastly, we also know that this group, for various reasons, is higher risk, not only of exposure, but also of more severe outcomes because they have less access to testing, maybe less access to healthcare, and often also comorbidities are disproportionately higher in these socio-demographic groups. Because WHO finds, because we have realized how immunization deliveries have been impacted of other vaccines, we have put health workers engaged in immunization delivery very high up in our stage. And here you also see that we put up the teachers very high up. This is not just based on risk assessment or modeling, this is based on the value. And our value was to put child development very high, and then so we would probably disproportionately give a higher value to teachers to make sure that schools can continue. This has a lot of other issues which can be discussed. In stage 3, when you have a little bit more, we would give it to the remaining teachers, other essential workers, pregnant women, and here I want to give a little caveat. Pregnant women, as we know, are at higher risk of COVID deaths and ICU compared to non-pregnant women of the same age group. But the overall absolute risk is still far lower than the age-based risk assessment. Plus, we have all the results from the first phase 3 trials will not include pregnant women. We will not have efficacy data and safety data in pregnant women. We are dealing with some very novel platforms. So that's why pregnant women needs to be discussed separately. And then we would go for all the other groups that are still remaining. I'm coming almost to the end. So here I just want to show you what other countries have done. I will not walk you through these tables, but reassuringly, all the NITACs, or that includes the JVCI in the UK, the ACIP in the US, and various other national immunization technical advisory boards all come to the same age-based risk stratification. First health workers, then age-based risk stratification. Here the UK is very explicit. They say with initial supply, we start with those in care homes, go 80, 70, 65, 65 plus high risk, etc., and go down like this. And you also see from Canada, Chile, USA, they all have very similar conclusions as we had and that's of course also reassuring. So this is my last slide. We have started as a SAGE working group to define the values. We use the values to then set the public health objectives. We use the science and the data and the modeling available to develop a prioritization framework. Now we need to include those elements into vaccine-specific recommendations. The phase 3 trial results may come up soon. We have had the interim analysis from Pfizer. That is not a phase 3 trial analysis, remember that. So we're still waiting for phase 3 trial results of the full population. We also wait for licensure, and then WHO through SAGE will formulate their vaccine-specific policy recommendations. And thank you very much for your attention.
Annelies, thanks to you. Congratulations for the excellent talk. An applause. We'll make it virtual because we are not in an auditorium, but I give you an applause. It was a fantastic talk. I'm gonna say that it reminded me when I was 8 years old and I watched Ghostbusters and I only wanted to see it again and again and again. So it's a pity we didn't film your talk and I cannot see it again. We have many questions and we don't have a lot of time. How much time do you have to take a few questions?
I have all the time.
Perfect. We too, and I think such a fantastic talk has led to many questions. And I will try to read them, some that have been written in the chat. And then if some of those that have the questions and I did not represent it properly, please interrupt me. I will try to be straight to the point. I think I speak on everyone's behalf on congratulating you for the fantastic talk so that we can go straight to the point of the question. The first question comes from Veronica. She asked about the issue of corruption. We know in LMIC, in many countries as well, corruption is a very important issue, and that might play a role in the distribution of the vaccines. How to tackle corruption, how to deal with it?
Yes, so we are all aware. We know we can put up the nicest values framework if it doesn't feed into the countries. There's not much that WHO can do in terms of policing. So I cannot really give you a good answer. This requires a very specific within-country approach, and we have a working stream at WHO called a delivery. So vaccine delivery that has to deal with all these issues. But in the end, WHO can and will not police countries. Thank you, Annelies.
Second question from Mark. How to bring politicians and others into a reality check? There was this announcement yesterday from Pfizer, the vaccine is coming, then the politicians, Boris Johnson and others are saying vaccines are gonna be distributed. While even if we start vaccinating, we won't be back to normality for a while. How can we bring this reality check to people and to politicians in particular that are communicating this?
Yeah, it's not only politicians, also about stock markets here, right? So the shares went up for Pfizer. So and indeed, this is a financial strategy that lots of companies have. So give early results, shares go up, etc. So it's communication, consistent communication. We need phase 3 trial results. It has to go through a rigorous regulatory process. Then a policy will be established, and then it will be rolled out. We are planning for rolling out now, but we can only do it once we have the policy in place. And I think this communication must be consistent. And I can tell you, if we don't do it, the issue about vaccine hesitancy or anti-vaxxers is as big as the problem of COVID. So we need to deal with all those who are driving it, pushing it forward, and also those who are hesitant. And it's to them that we say we are not rushing it. We are not cutting corners. We are doing due diligence. We want a good and safe vaccine.
Our colleague from SPN, Thomas Abel, actually was talking about that issue as well in his question about the communication. We've seen a lot of resistance and skepticism from the public. We've seen countries with levels of up to 50% that they don't believe in the vaccination or they don't want to be vaccinated. In the UK, up to 20%. How can we improve that communication to the public? There is so much confusion, so much misunderstanding, and how can we guarantee that once we have vaccines that work, people do want to put it?
Social media, QAnon, conspiracy theories, they are our biggest enemy, politically, emotionally, mentally, socially. It is the biggest challenge of our time. WHO and academia and various institutions are reacting, and there's now there's now a science around infodemic. There's now more knowledge how to tackle infodemic than we've ever had, but we still have the problem. So I'm not a communication specialist, but I can tell you that the London School has a whole team just working on this. They do social media analysis and then do proactive, proactive and reactive responses, writing key messages, etc. It is an ongoing problem, and this problem will only become bigger. And this is my biggest headache. That's my biggest concern. However, as for your, we are all doing these kind of surveys. I can tell you, I don't trust the surveys of today. Once you have a good vaccine, it will change. People will want it, and there will be fights. People will run for it. There will be corruption, as someone said, and they will run for it. So I'm not actually, I'm not so concerned about it now, because initially we have such limited supply. I can even say, oh, you won't get it anyway. It is only the people at high risk. So I'm not. The whole infodemic is a big threat, but here I think it will in the end come also to our advantage, maybe hopefully in the future, in the near future.
Thank you, and that is indeed an excellent point. Once the vaccines are there, maybe the situation changes. I keep on getting congratulations and excellent talk comments here. Just before I go into the next question, the next question I'm going to try to bring Taulan and Harunor from Australia together in the same question. Taulan was asking about many of the trials, the high risk groups, including the elderly, are not well represented. And that was also the question from Harunor. How can we actually have a vaccine that is going to work, and we're going to have evidence that it works on those people that we're actually going to be administering it for the first instance?
So I can reassure you, all vaccine trials, all vaccine developers are including the high-risk groups. So that means they're really trying to have at least 20 to 30% of their subjects to be older than 60 or 65. They're also including comorbidities. I saw one, Johnson even includes nursing home residents. So it will be addressed. However, Harunor and everyone else is right. It is not in the sample size is too small for as a primary endpoint. And so we will need to live with some uncertainty when we look at the first phase 3 trial results. But if there obviously is a signal of safety or absence of efficacy in these older groups, I can tell you we all have to rethink. So then we have to vaccinate everyone around the older people. But for that strategy to be effective, as I said, you need a high vaccine coverage rate. So this is challenging. So we all hope. I mean, if a vaccine has no efficacy, we will not roll it out, right? We will not do policies, but this is an issue.
Another aspect that was raised by Nicola Lowe from ISPM as well, is that beside the high-risk populations, there might be an issue with antibody-dependent efficacy. I mean, are the trials including people that had already SARS-CoV-2 in the past?
Yeah, so this is a special interest of me, because I spent 20 years of my life on dengue, where we, found out there was a serostatus dependent lack of efficacy and in fact an increased safety. So this is an important question, and will become more important as obviously the phase 1 and phase 2 usually excluded those who were positive. The phase 3 trials include, and they take blood from most of these people, and there are a priori statistical analytical plans to look at these questions. Nicola, I can tell you what we are not going to find out, though, is for dengue, the problem was found 3 years after administration. We actually, from an immunological and even scientific point of view, we are actually less concerned about vaccine-enhanced disease than we were a few months ago. But if there is something that occurs 3 years later, we will not notice it, obviously, in the initial. So yes, we are looking at it. There will be stratification for serostatus, but our initial not intuition, that sounds non-scientific. Our initial sense from the literature is that it's less of a problem than we thought a few months ago.
Sometimes even in science, intuition is important, but thank you, Annelies, and thanks, Nicola, for the question. We have a question from Sven Strebel, one of our PhD students. He's asking, how do you imagine, or how could you foresee, and this is an element of intuition here, that the long-term effects, the findings on long-term effects could have an impact on the priority of the population to be vaccinated?
Can you rephrase that question? So if I understand, the beauty of this age-based prioritization that we have is that it follows the influenza strategies. So we can just, pull out the influenza strategies and use those strategies. Now, they are well developed for high-income countries, but they are not developed for LMICs. And this is the whole problem. For delivery of a vaccine that is now clearly geared towards an older population, most countries in the world do not have programmatic delivery systems to roll it out. And therefore, we have a work stream at WHO. I'm not part of it, but I listen sometimes to them. We have a whole work stream now thinking through the issues. How do we roll out a vaccine to older people who may not normally go to a healthcare system, who live in multi-generation families somewhere in the corner in India or wherever? So this is a programmatic issue that needs to be dealt with. I can also maybe here add, as I said, there are lots of discussions. Some people said we should just vaccinate those persons with risk groups, so morbidities, so including younger ones. And then we all came to the conclusion that programmatically, that's very difficult. It's very easy to say, you all come if you're older than age 65. But if you say, oh, well, you have to show proof of evidence that you have diabetes or hypertension, you need to go to your GP, give a document that you have the disease, only then you can vaccinate, is programmatically harder. It's not impossible, and we may do it, but it needs a little bit more thinking than probably an influenza-like age-based stratification that we have for influenza.
Thank you, Annelies. I think the question from Sven was about the findings as we start finding about long-term effects, but we don't know that yet. That will take some time to be able to obtain that information.
This is important because and in fact, this is the so-called long COVID and the long-term consequences in COVID survivors, or even those who have mild COVID. There's now increasing evidence that there's long COVID that will impact your DALYs. And we have not used DALYs as our primary outcome because we did not have enough data to actually calculate the DALYs.
Yes, thanks. One question from Clara Postfit-Barb, which you already addressed during your presentation, is about pregnant women. Would they be considered as priorities for vaccination? What do you think?
All right, we have many discussions on pregnancy. So the initial data that came out a few months ago was that actually pregnant women are not at higher risk in comparison, for example, to influenza. For H1N1, it was clear they were at higher risk. But now that we have more data, there's now a strong evidence base that indeed pregnant women have a higher risk of more severe disease, hospitalization, ICU, and death. But that's in comparison to non-pregnant women of childbearing age. And the absolute risk in pregnant women is still relatively low compared to an older person who has no disease, not pregnant, but also no other disease. So the exponential growth in age is so striking for this disease that pregnancy is a risk factor, but not the highest risk factor. And given that we always have to do benefit risk assessments for pregnancy, and given that very clearly we will not have enough data on safety from the phase 3 trials, I personally would only vaccinate pregnant women when I really know that the vaccine is safe.
Thank you. Another question from Ralph Houts. He's asking regarding serostatus. Will serostatus be considered or evaluated before vaccination, and is it being evaluated on the pre-vaccination evaluations? the efficacy on the of the recipes. Yeah.
So in terms of phase 3 trials, yes, serostatus is taken into account. So in most trials, at least a large subset, if not all, will have blood samples taken, and then you can do you can do an analysis stratified by baseline serostatus. The second question is, though, assuming that the vaccine is safe when you already have been exposed and you're positive. The question is, should you tell people who have already had the disease not to be vaccinated? So we had long discussions, and we came to a consensus, but there's no scientific robust conclusion yet, because we need more data. But because we all don't know the duration of natural immunity, we think that the vaccine would be still a good booster, and we would, with our current knowledge, we would not screen for prior serostatus, for prior infection. And also knowing that the antibody levels decline, you can't rely on the serological assays. We have, as a working group, we came to a conclusion that we would not screen for prior infection. It's programmatically a disaster if you have to take a blood first and then you vaccinate. However, having said that, if you have a very high seroprevalence, 30–40%, and it makes economically sense to only give it to those people who are negative, we may in the future come to the conclusion we should screen prior to administering the vaccine.
Thank you, Annelies. I think that answers as well the question from a public who says, thank you very much, excellent presentation. The next question comes from Dorta, also from ISPM, asking about the cold chain. As we saw, for example, yesterday, the vaccine of Pfizer, it would require to be stored at -80, and many countries, many settings, inclusive in these countries that we live, do not have the facilities. How are we going to supply the fridges or the equipment that are required to facilitate this cold chain distribution?
So the ultra cold chain problem that Pfizer-BioNTech's vaccine has is indeed a headache for any programmatic rollout. Now, they have, of course, plans. I mean, they've been thinking about this. So they have a very good plans in place how to distribute the vaccine in, require the ultra cold chain, keep it in centralized places. And then it can be used and then on ice, on dry ice, for a limited amount of time. So this vaccine will not make a rollout easy, but remember, initially we have so little vaccine, we would keep it in certain centers and people would need to come to these centers. You will immediately say, well, about all these old people, 85 in their nursing homes, very difficult for them. So it is an incredibly difficult problem that we are already thinking through, obviously, all of us. But with limited vaccine supply, we can probably still address it. And I can also tell you that the company is working on technical solutions so that in the end, it can be stored at 2 to 8 degrees in a fridge for a certain limited amount of time. So yes, I think in the future we'll have solutions. For the time being, we have a problem that we have to tackle, and it will cause headaches. And it may also mean that the vaccine is skewed towards high-income countries, which would go totally against everything we've developed in SAGE.
Thank you. We have a question from Kathy, also one of our PhD students. Kathy is asking about how well allocation equity between countries will be ensured, and how are we going to help countries that have severe international political sanctions or barriers, or that are not recognized by other countries, let's say, for example, Iran, Taiwan. How can we facilitate these two different aspects?
So if a country is signed up for COVAX, then they have an automatic right for equitable distribution. So whether it's Taiwan or Iran, if they have signed up, they have a right to this equitable distribution. How that then, whether there's corruption somewhere here and there, could be, but I think the intent and the mechanisms are being thought through at incredibly high stage that involves everyone from a national to regional committees to politicians to, everyone is involved to make sure that this is done equitably. And maybe that is also the strength. We started this whole thinking, already in April. And so the mechanisms are more or less in place, but you have to be part of COVAX if you're a country outside of COVAX.
Thank you, Annelies. We have a very interesting questions of George Cararigas. All the questions are very interesting, by the way. But he's asking about sex. How are we going to take sex into account? The differences that we have seen in risk or mortality that is still being debated, but is being shown. So is sex going to be taken into account for the allocation, for the prioritization, or?
I think it's a valid question. If male have an almost 2 times increased risk of death, then some may argue you would need to prioritize men. We have discussed that also at length, and we came to a conclusion. First of all, it's not good to communicate. Secondly, if you look at the deaths amongst healthcare workers, it is clearly the women, not the men. It is the women because they have a higher risk exposure. There are more women in healthcare jobs. So I think to smoothen out the communication problem, we go gender neutral or indifferent. Yeah, over.
Thank you. Next question is from Andreas. Andreas asks, is the years of life loss metric an appropriate metric to quantify the burden of COVID-19? Yeah, we've seen calculations in Scotland and in countries like Colombia. We've seen huge losses in years of life loss, but I let you answer that question, please, Annelies. I shouldn't be answering these questions for you.
So we years of life loss, YLL, is one of the outcomes that we are looking at in addition to deaths, in addition to just infections, etc. And I must say, my intuition was that we would do YLL-based stratification, because what really counts is YLL. How many lives, how many years of life can I avert through a vaccine? Yes. And to prevent a death in a 60-year-old, maybe better is the wrong word. It may be justified based on YLL thinking compared to someone who's already 85. So, but the modelers proved me wrong. The modelers showed that, in fact, just going for deaths almost has the same outcome as YLL. And that's because it is so exponentially driven by increasing age. So yes, so basically the outcome, that means the age-based stratification, is the same whether you use YLL as your modeling outcome versus death.
Thank you. A question from Christina Mesa, also from ISPN, one of our PhD students, is asking, some countries have agreements with particular vaccine developers. Besides COVAX, they made the unilateral agreements. Other don't want vaccines if they are communist. You know how it goes. So how to take this into account and the preferences? In the moment that you get one of the red vaccines that some people don't want just because of the ideology, how can we tackle these different issues? I guess that's the question, Christina, right? Yes.
Yes. So COVAX obviously tries to. I think COVAX is a mechanism to even out the issues between the vaccine platforms, and then we will, choose a vaccine. We will choose many vaccines based on a whole variety of attributes, which includes, how many doses, what is the storage, ultra cold chain will go out if we have a better vaccine. What's the expense? What's the convenience? What's the efficacy, safety? Lots of criteria you could think. What's even the scalability? The mRNA vaccines cannot be scaled up to 2 billion. Cannot. So we have to work with all the different platforms. So COVAX will make sure that we will have access to the best, negotiate a price, and it will be equitably distributed. Yes, in addition, countries have bilateral agreements. I think also Switzerland, UK, we all have bilateral agreements. And so indeed, it means that high-income countries can top up to above what they get from COVAX. And that is inequitable. What is the solution? I don't know. COVAX is the only mechanism that we can use, but we can't prevent countries from going into bilateral agreements. Did I answer the question? Did I miss something?
Yes, no, I think you did. And also just to add that now with the political changes, maybe one of the other countries that was missing in COVAX might be joining in the future. That's the rumor. You know, we're missing Russia and US, so that might change things in the future, hopefully for the better. But I'll go into the next question, just a message from Chloe, who wants to say, excellent talk, very instructive. And a question from Alicia Rosselló. What is your expectation on the timing of the 3 phases of prioritization that you just have outlined in terms of timeline of distribution?
Yes. So of the 3 steps that I outlined, values has been done, ticked off, published. The prioritization roadmap done, was SAGE endorsed, WHO Director General endorsed it, is now going through all the countries, has been published on the website. I give webinars the whole time to all the countries in the world, including Russia. And now we are waiting for the phase 3 trial. And we are, it's nail biting because, you know, we don't want to wait for the phase 3 trial results to be out and then start policy making. We want to go parallel with the regulators. So I cannot give you exact dates, but I do think that by December we'll have the first phase 3 trial result out, and several vaccines will come, I think, in January, February, where they will be out, and we have to make immediate policy recommendations. So to do immediate, we will not wait for the published data. We will be in contact with the regulators. We will speak to the vaccine developers, speak directly, SAGE, you know, and they will share data as they have done in the past for all the other vaccines that WHO gives recommendations on, so that in the ideal, it would be a matter of a day or 2 or 3 or maybe a week between a licensure and our policy. And so that countries then go out. But the bigger problem is the delivery. You know, the countries have to start now thinking, how do we deliver a vaccine to older people? And how, or because as we know, the very first thing is, how do we deliver it to healthcare workers? What are the best delivery systems to ensure that the healthcare workers trust, there's a good compliance, and that it's really done in very, very, very quick, very rapidly. You know, we don't want a year to roll it out. We want a few weeks to give it to all healthcare workers. That requires coordination and planning.
And indeed, this is advancing so fast, Annelies, that I have to ask you again for another date to see whether you can come back and give us another talk, maybe in January or February, this time about distribution, equity, etc., because this is really rolling fast. And I think I agree with all the comments, and everyone agrees with me that the talk was fantastic. If anyone has a burning question, please raise your hand or write it. I don't see any more questions. Annelies, you know, we live very close by. Bern is very near to you. I hope to see you more often in ISPM, and I thank you for this fantastic talk. It was very entertaining, very informative, very instructive, and people keep on writing here. Fantastic talk. Thanks, Annelies. Great talk, etc. So thanks a lot, and I hope to see you again, or ISPM or here talking about the rollout of the whole vaccination program. So thanks everyone, and thanks everyone that joined us from all different places in the world. It was a fantastic discussion, and especially thanks to you, Annelies.
Thank you so much. Thank you.
Bravo. So thanks everyone, and I hope to see you in the next seminar of ISPM. Have a great day.